that are part of the 34th Orthocon, which is going to be held in December 2020. So here today we have a very interesting topic. It's PGA. We are going to discuss various aspects of pediatric bone sarcomas as we face it in our local environment. I'm Dr. Aisha Saeed. I work as assistant professor and head of department of pediatric orthopedics at Children's Hospital Faisalabad. It's relatively a new department, since is a very big city. It's the third largest city of Pakistan, so I get to see a lot of these challenging cases in my new hospital. Before we proceed on to the meeting, I am really honored and humbled to introduce you to our distinguished expert panel that has joined us today. We have amongst us Professor Syed Muhammad Awais, and of course, he needs no introduction. He is a teacher of teachers, and he retired as professor and chairman of orthopedics for more than 30 years at Mayo Hospital, Lahore, King Edward Medical University. He has a wide and vast experience of managing very, very challenging musculoskeletal tumors. Especially, he has a great insight into the custom-made prosthesis that we locally actually arrange and design for our poor and less resourceful patients. Also joining us is Professor Masood Omar, and again, he needs no introduction. He is the chief of the orthopedic surgery at Al Khan University. He's widely known amongst the orthopedic community nationally and internationally. And he has a great insight into orthopedic tumors. He is always seen on the front lines in the orthopedic oncology forums. And I'm really, really thankful that he really helped me set up this webinar, and this meeting is successful because of his active participation. And also joining us are Professor Abdul Latif Sami and Dr. Mumtaz Hussain from Children's Hospital, Lahore. As we know, Children's Hospital Lahore is the biggest and the largest children's hospital of our country. So from that perspective, we get to see a lot of pediatric bone tumors over there, and they surely have a vast experience catering to these patients. I'm also humbled and really obliged that Dr. Zishan Khan has joined us from Peshawar. He works as assistant professor at Hayatabad Medical Complex. He is trained from UK and has, again, he's quite experienced and deals with a lot of challenging tumors at his center, and is very, very academically involved in all the meetings that are going on nationally, internationally. So thank you very much, all our prestigious faculty. Unfortunately, I didn't have photos for Dr. Sadaf and Dr. Bilal. So Dr. Sadaf is a pediatric oncologist who has joined us from Al Khan University, and also joining us is Dr. Bilal Mazhar Qureshi. He is a radiotherapist. Since most of the faculty and the members who are joining us are very senior, esteemed faculty, so I have kept the presentation a bit more simple. It is just a case-based presentation, and I will present these cases and point different questions to our faculty in between, and take their opinions so that we all understand their perspective of the different challenges that we face. Okay, so just for a little bit of introduction, we all know that primary malignant bone tumors, they account for 6% of all the childhood malignancies, and majority of them, as we know, are either osteosarcoma or Ewing sarcoma, like greater than 90%. So the various prognostic factors that have been described in various papers till date are like presence of metastasis or not. Well, then it also, of course, depends upon, it's been established that a major prognostic factor is the size of the lesion, then what is the location, the grade, presence of fever, anemia, or elevation of lab values like LDH, amylase, age of presentation. Then when we talk of Ewing sarcoma, of course, it is this specific translocation, chromosomal translocation between 11 and 12 chromosome versus 21 versus 22 chromosome. And of course, the histological response to neoadjuvant chemotherapy. And I'm sure there are many other prognostic factors, and many of the faculty will like to add to this as well later on. But these are the most prominent ones and the established ones. And the survival, of course, depends upon many factors, but the two more distinguished prognostic factors that determine the survival of these patients is either or not the disease is localized to extremities or to the axial skeleton, and also either or not the disease is metastasized at the time of diagnosis. So this primarily depends, especially when we talk of Ewing sarcoma. So like in our cases where we mostly diagnose our cases at the time of metastasis, the 5-year survival is already reduced to 29 or 40%, which is really low. And we all know that the gold standard is limb salvage, however, and this has become easier in the recent times because of advances in imaging, because we are able to understand the tumors more with all these invasive modalities that we have. And also, of course, because of the multi-agent chemotherapy, which plays its roles to downstage the tumor. So the 5-year survival has really increased from where it was 10 to 20% to 60 to 70%. Now, these various points that I jotted down for limb salvage surgery, I know all these very senior faculty members, I am sure that none of these surgeons even consider these factors nowadays before they think about salvaging a tumor, a limb, sorry. So perhaps limb salvage is possible in any patient in recent days with our recent advances in surgery and the other modalities that exist for tumors. Okay, so with this, I move on to my first case. This is a very, very interesting case. The first X-ray that I have projected, it's not of a very good quality, but this X-ray actually comes 4 years before the presentation of this patient. So this patient at that time was only 4-year-old. And as you can see on the screen, that he has suffered what looks like a simple fracture of the proximal radius. And this fracture, of course, he went to a local hospital, and they placed, like any child with this kind of a fracture, you would always place such child in a cast. So he was placed in a cast, and the fracture healed in 6 months' time. But unfortunately, like 4 years later, this child presents with the lesion as you see on the screen. Okay, now here comes the interesting part. I'll just request Professor Masood Umar to intervene here. Okay, now if a patient with such a lesion presents to you, sir, what will be your line of action? So my question was that a patient presents with such a lesion. What we see is an expansile lytic lesion, which is partially disrupting one of the cortices. What will you consider in this patient? Will you think it's a malignant lesion, or you will treat it as a benign bony lesion?
Gee, thank you. This has, first of all, we would consider age, location, site, appearance of the lesion. What is the lesion doing to the bone, and what is the bone doing to the lesion? These are, and then finally the matrix. These are anything cardinal 4 questions that we need to address. So the lesion is located. in the metaphyseal region abutting the epiphysis, and looks like a permeative border where there's no clear distinction, at least distally, of where the lesion is stopping. It is growing into the soft tissues and has a thin rim of calcification around the lesion. It has also caused malunion, crookedness in the bone, deformity. So it looks like an aggressive lesion. That's what I would say here. The lesion which has grown out of the bone.
Okay. So
So
like you.
differential can be a long list,
Hmm.
starting from benign diseases to malignant diseases.
But you will certainly like to investigate further.
Yes, of course.
So a little message that I want to project here. Unfortunately, this child went to a I don't want to name anyone, but went to a very senior orthopedic surgeon of our city, and they took it as a benign lesion. And as you can see, one X-ray on the right that I have put is from March 2019, and the next X-ray is from November. So the patient actually waited for a pretty long time before visiting any surgeon. So in November, when the other person saw him, they took it as a benign lesion and they did not investigate it any further. And unfortunately, this patient underwent a curettage and bone grafting at their center. And it was good decision that at least they sent the biopsy of this patient and turned out that. So as Professor Masoodova rightly mentioned, that the lesion was expanding into the soft tissues, was breaking the cortex. So probably it was a good idea to thoroughly investigate it before going in and thinking of it as a benign lesion. This is the picture from December 2019 when the biopsy was there, and biopsy said clearly demarcated it as Ewing sarcoma. And as you can see, this lesion now is involving the proximal 2/3 of the radius. And now it was referred to Children's Hospital Lahore, this particular case. So the chemotherapy was started. Patient belonged to Faisalabad, so they decided to come to Children's Hospital Faisalabad, and chemo was started. And after 6 wide chemos, this was the situation in May 2020 when I saw the patient in my clinic. He was finally referred to me for a surgical resection. So here I will request Dr. Sadaf to kindly intervene and tell us what is her perspective on the type of chemo and the number of sessions of chemo that she thinks that an 8-year-old child should get at least before getting into a surgery. How she plays about it.
Thank you so much, Aisha. So, I mean, this is like 50% of cases of pediatric sarcomas in our setup present like this, where there is a delay in diagnosis. People are not aware of the fact that children can get bone cancers, particularly in the younger age. So sadly, this is something that we see all the time. Now, obviously, this kid was delayed by like almost a year in his diagnosis, roughly. So as far as the Ewing sarcoma is concerned, at least the prognosis and outcome of Ewing sarcoma, if it is localized disease, is certainly better than osteosarcoma. At diagnosis, I don't know what sort of staging workup was done on this child, but and I'm sure you all are aware of it, but it is really important that for patients with Ewing sarcoma, a complete staging workup needs to be performed, which includes a bone scan to look for any other lesions in the rest of the bones. A CT chest is really, really, really important to look for mets in the lungs, because that is the most common area where this tumor likes to go. And then the third thing is a bone marrow biopsy, because that is the second location where this tumor likes to go. So a bilateral bone marrow biopsy is mandatory. So we have a really good setup here in Aga Khan, where Dr. Masood and Dr. Bilal and myself, so we sort of, always sort of discuss patients at presentation. If I get the new patient, then I send them to Dr. Masood up front. If Dr. Masood gets them, then I, get to see them. So for example, if Dr. Masood is going to take the patient for a biopsy, sometimes at the same time, especially agar bahar se biopsy karwa ke aa rahe hote hain, and if we have a suspicion that this is a cancer, then we do the bone marrow biopsy at the same time in the same anesthesia. Otherwise, Dr. Masood does his biopsy, and the first thing then that we schedule the patient for is a bone marrow biopsy. So I think it's really, really crucial that, the staging workup is done adequately. Now, if this kid really has localized disease, which means that the disease is only limited to this particular bone, then white chemotherapy is a very reasonable choice of chemotherapy. The drugs are pretty much the same, whether you use the white regimen, which includes these 4 drugs. But remember that, there is new adjuvant chemotherapy, local control, and then further chemotherapy. So for Ewing sarcoma, at least 13 to 14 cycles of chemotherapy has to be given for it to be systematically cured completely. So I'm completely in agreement with this choice of chemotherapy. And after local control, this child needs to get 7 more cycles of VAI, which is vincristine, actinomycin, and ifosfamide.
Okay, thank you very much, Dr. Sadaf. Sorry, I forgot to mention here that it was a localized disease and we had done the staging workup. The bone scan came negative for other areas, and the CT chest were clear as well, and he also had a bone marrow biopsy. But as you mentioned, unfortunately, the child had to go to very different centers in order to get all this workup done. Which is perhaps a very challenging and agonizing thing for the parents, and that's why most of these kids, they get, they don't get the state-of-art treatment. Okay, so here I would like to ask Professor Awais Saab for his opinion that what he thinks this, like when we have a localized disease and it's involving the proximal 2/3 of the radius. I took the MRIs to the radiologist and thoroughly discussed it. Alna was not involved. As you can see on the right side of the screen, we have the images from December, and here we have images from March. So the tumor has considerably reduced in size. So my question to Professor Awais Saab is that how we proceed about it now.
Thank you very much, Dr. Aisha, for organizing this seminar on a very, very important topic. बुनियादी तौर पे तो ट्यूमर्स के जो जनरल प्रिंसिपल्स हैं, ये मैलिग्नेंट ट्यूमर्स के, जैसे पहले भी डॉक्टर साहब बता रहे थे कि न्यू एडजुवेंट ट्रीटमेंट तो तमाम ट्यूमर्स के लिए यूनिफॉर्मली इम्पॉर्टेंट है. प्रेपरेशन के बाद जो एक्सीजन है उसका बेसिक प्रिंसिपल तो वाइड मार्जिन एक्सीजन है, और न्यू एडजुवेंट ट्रीटमेंट के साथ सबसे बड़ा फायदा ये होता है कि ट्यूमर आसानी से रिसेक्टेबल हो जाता है और सर्जन के लिए आसानी हो जाती है टिश्यू प्लेन्स में ट्यूमर को आइडेंटिफाई करना, उसके मार्जिन्स को प्रिजर्व करना और एन ब्लॉक उसे एक्साइज करना. और जैसे डॉक्टर साहब ने अभी बताया कि उसके बाद फिर जो इसकी ट्रीटमेंट है, बाकी की कीमोथेरेपी साइकिल्स जो हैं, ये इंतहाई ज़रूरी हैं ताकि डिजीज़ जो है ये टोटल रिमिशन में रहे और इसकी जो सीडलिंग है उनका कोई स्कोप ना रह जाए.
Yes.
इसके अलावा फिर बाकी चैलेंज जो रह जाता है वो रह जाता है हाउ टू रिकंस्ट्रक्ट द डिफेक्ट. अब वो वेरी करता है फ्रॉम एनाटमी टू एनाटमी एंड रिसेक्शन टू रिसेक्शन एंड द चॉइसेस अवेलेबल right from grafts to various form of grafts to prosthesis. तो आई थिंक जो आपने पहले आइडेंटिफाई किया कि यहाँ पे चूँकि अंडर वन रूफ ये सर्विसेज अवेलेबल नहीं है, तो मरीजों के लिए और ट्रीटिंग फिजिशियंस के लिए ये उस वक्त तक तो चैलेंज रहेगा जब तक कि हमारी ये जो वर्कअप करने की फैसिलिटीज़ हैं, उसके बाद जो न्यू एडजेवेंट और एडजेवेंट कीमो रेडियोथेरेपी की फैसिलिटीज़ हैं, सर्जिकल फैसिलिटीज़ हैं, ये जब तक अच्छी कोऑर्डिनेटेड और अच्छी क्वालिटी की ना हो जाए। अल्लाह करेगा इंशाल्लाह ताला, आप सब लोग मेहनत कर रहे हैं, हो ही जाएगा आहिस्ता आहिस्ता।
So, as you said, we decided to do a wide marginal resection for this tumor. And after thoroughly discussing the imaging with the radiologist, we were told that the posterior introitious nerve is actually involved within the tumor. So here, as you can see, where the dissecting scissor shows actually the nerve which was going through the tumor. So the posterior introitious nerve had to be sacrificed. And as you previously mentioned, that the reconstruction will depend from site to site. So here in the proximal 2/3 of radius, even if there are series of reports in the literature that even if you do without reconstruction, patients usually do very good. The only problem that they often have is actually some migration at the distal radioulnar joint, which can be prevented if we initially put a K-wire, hold it with the K-wire for 6 to 8 weeks. So this is exactly what we did at our center. So the tumor was removed en bloc. Probably the best approach would have been the Thompson approach, but as you can see, the previous scar which was made to do the curettage by the other surgeon was in the Henry's area. So I had again, I had to go in through the same area in order to take out the scar along with the tumor. So, sir, here I also want to ask you that how much important it is that we take out the scars that are previously defined. How much important is that?
In aggressive malignant tumors like Ewing sarcoma or osteosarcoma and others, it is very important that the potential tracks they are excised along with the tumor so that local recurrence is minimized as far as possible. Regarding radio ulnar function, अगर 6 महीने साल के बाद महसूस होता है कि डिस्टल रेडियो अल्नर जॉइंट में कुछ प्रॉब्लम आ रहा है, तो ये तो जो असल इम्पोर्टेंस है वो तो है गेट रिड ऑफ द ट्यूमर और मरीज जो है ना वो डिजीज फ्री हो जाए. उसके बाद हमारे पास वेरियस चॉइसेस हैं रिकंस्ट्रक्शन की. फ्री फिबुला है जो हम अपर रेडियस के लिए यूज कर सकते हैं. हम सिंगल बोन 4 आर्म बना सकते हैं जिसमें हम अल्ना और रेडियस को आपस में फ्यूज कर देते हैं और हमें एल्बो पे फ्लेक्शन और रेस्ट के ऊपर प्रोनेशन सुपिनेशन मिल जाती है और स्टेबिलिटी भी रहती है और फंक्शन भी ठीक रहता है. लेकिन ये सारी बातें सेकेंडरी और बाद की हैं. सबसे पहली बात तो ये है कि मरीज का जान छुड़ाई जाए ट्यूमर के साथ.
And another question I have, if Professor Masood Omar can answer for me, what, like you can see in the MRI in December. So the MRI in December shows the extent of tumor, a big extent of tumor into the soft tissues. But of course, after the chemo, it has significantly reduced. So my question is that when the tumor goes into certain soft tissues, isn't it important to remove all these soft tissues even when the tumor has regressed after chemo, or we consider that tissue healthy?
The fact, and thank you, Dr. Aisha, the fact that the chemotherapy has especially यूविंग में हम बहुत remarkable response देखते हैं. The fact that it has regressed and reduced from its original status of being a huge tumor to now a reasonably limited tumor in the MRI picture on the right. That's why a repeat MRI is done before surgery and after neoadjuvant chemotherapy. The idea is to give a comparative analysis of what it was before and what it is now. So I consider this as my pre-operative MRI, and my operative decisions are based on this MRI now, which is on the right. So the
Okay.
muscle groups and the compartments, flexor or extensor that are involved now, those will be resected as dictated by the MRI. So we do consider resection. I know they are contaminated, but chemotherapy is very advanced now. They will certainly take care of the disease before and after the surgery. My job is to remove the lesion as it appears on the current MRI after chemotherapy.
Okay, thank you, sir. Now I move on to the next case. This is very interesting. I will request Dr. Zishan to be on board for me for this case. Again, this child had a lesion in radius on this X-ray on the left, and as you can see, this lesion again is not contained within the bone. This was a 4-year-old boy, and this child again went to a big setup in Lahore, where it was taken as chronic osteomyelitis and curated. But luckily, they also sent biopsy, so which was the only good thing that happened to the child over there. And this was in February 2020. And the next X-ray that you see on the right is in March 2020. I will request Dr. Zishan, and of course the biopsy came out as Ewing sarcoma, to comment on this situation.
Actually, Dr. Zishan has left, yes. He has an emergency in family, so he could not able to answer your question.
Okay, so let's ask Dr. Mumtaz then. The reason why I place these radiographs and the importance is because a lot of times children with the tumors, they present with a picture which is similar to chronic osteomyelitis. And most of the people, sometimes they jump into these patients without properly investigating them, without even considering the possibility of a tumor, and which results in a very, the tumor spreading beyond the margins, and in fact involving all the soft tissues, and patients sometimes end up losing their lives. So I'll go to Dr. Mumtaz and request him to comment on these X-rays and how he will like to proceed about it.
Can you hear me?
Yes, sir.
Okay. Although this is a little bit advanced stage, it must be biopsy or get suspicion in early stages. But you know, on my this X-ray on my left side, it says involved almost diaphyseal and distal from mid half to distal whole part of the radius have involved. I'm not. Let's see on this radiograph. This MRI will show the extent of its intramedullary extension, but it seems that almost 2/3 or 3/4 of the whole radius is involved, along with the soft tissue expansions, cortical breach. I can see on my this radiograph on my right side, there is expansion, and along with there is breach and soft tissue expansion.
Okay, sir. So of course, but the idea here is be really vigilant as a surgeon.
Yes.
Most of these children are presenting to us as primarily to orthopedic surgeons. And we sometimes looking at the financial condition of the children, so we sometimes we neglect the basic tumor workup, which is very critical for all these children. So, that's why the unfortunate thing happened to the child. And as you can see on the right side, after the curettage, what happened, the tumor had expanded already. And the first X-ray from February 2020, the next X-ray is from March 2020. And here I will show you the X-ray from April. So in March, we had done the basic staging workup of the tumor. It was still a localized disease, and it was still a localized disease. However, it had expanded exponentially locally. The patient had undergone 2 chemotherapies, 2 wide chemos up till now. And at this stage, the oncologist referred the patient to me because the tumor was already expanding in size and not responding to chemos. Here I would like to ask Dr. Sadaf what does she think about it? That if the child does not respond to 2 or 3 sessions of chemotherapy, should we proceed with the surgery, or should we wait for for at least for more sessions to go on?
So I think this is a very, very difficult situation. Ewing sarcoma is generally a very chemosensitive as well as radiosensitive tumor. So in a situation, if your tumor is growing on chemotherapy, the prognosis is extremely dismal. It is extremely dismal. And in that situation, I think immediate local control should be sort of considered. Now, at this point, second-line chemotherapy or change in chemotherapy can be considered. But remember, if it hasn't responded to first-line chemotherapy, chances that it will respond to second-line chemotherapy are also pretty low. In terms of that, giving further chemotherapy and whether it will work, I think it is less likely if it is growing on this chemotherapy.
Okay.
Now there are a couple of things that I would like to sort of highlight over here. It is really important when we give chemotherapy, we sort of understand that, there are certain principles of chemotherapy. For example, the duration of chemotherapy cycles. So wide chemotherapy generally requires an interval of 3 weeks between each cycle. Now, the current standard of care that has been used is the compressed chemotherapy cycle, which is VDCIE, and that is given every 2 weeks. That has become the new standard of care, and both the institutes in Karachi, that is Aga Khan and Indus, we are using that regimen. So the only difference is that wide does have a 3-week interval, versus the VDCIE chemotherapy regimen, which has 2 weekly, which is a little bit more intense in terms of giving the chemotherapy duration-wise. So it is, if in order to give this child a fair chance, maybe VDCIE chemotherapy could be tried. Now, a lot of our centers in Pakistan have not adopted this because they're worried that this is very toxic because we're giving it every 2 weeks, but that's actually not true. This has been tolerated very well with the moderate amount of toxicity. And we use supportive medicines like GCSF or Filgin in between the cycles, and we have seen really, really good response to that chemotherapy.
Okay, so I have another quick question, that when the tumor is growing so fast, like from what I showed you in February to March to April now, are you, like when the chemotherapy is going on, are you scared that the metastasis is going to happen even while the chemo is going on?
So actually, yes, you are absolutely right. that if the tumor is growing with this speed, then definitely the chances of metastasis are there. And if this tumor were growing this rapidly, then I would definitely consider doing a CT chest at least to see if there are any lung mets. And if there are lung mets, then obviously, the boat has already left the dock, and things are probably really out of control at that point. But yeah, you're absolutely right that the chances of mets are definitely
So,
there.
so what is the wise thing to do then? Like we should immediately go for a surgery at this moment?
Now
Or
this
continue with
tumor,
chemo?
देखें अब आपको जो है ये सोचना है कि अब आप curative intent से treat, whether you're treating with curative intent or palliative intent. A tumor which has such a grave prognosis. Now, how can you surgically save this limb? I highly doubt. In that situation, then you have to consider palliative options such as radiation therapy. And Dr. Bilal is there on this forum, and I would really like his opinion on this, because I would definitely speak to the family and tell them that this disease is bad and we may not be able to sort of cure this child. And in this situation, I think palliative radiation should be considered as an option.
Okay. So let's go to Dr. Bilal. Dr. Bilal, please, can we have your opinion on this one?
So as already alluded that Ewing sarcoma is a very, very radiosensitive tumor. So historically, in the previous century, Ewing sarcoma, there was a time when Ewing sarcoma was treated only with radiation therapy, and it was successful in the sense of having local control. But mostly all of those patients relapsed distantly, and therefore the chemotherapy role was established. Comparing the local control that is achieved by radiation therapy alone in a non-metastatic setting versus a combination of surgery and radiation therapy, definitely radiation therapy alone would be inferior to that of when you have the situation where an R0 resection or even an R1 resection followed by post-operative radiotherapy can be given. So the results of radiation alone are not comparable to that with surgery, but it is a good option to go for local control with radiotherapy. But there are certain challenges, and the family has to understand that. And we often discuss them in our multidisciplinary tumor board meeting, that what are we expecting with radiation therapy and what do we try to achieve with radiation therapy that could not be done with with surgery or a combination of both. So the challenge I see over here is that the whole of the circumference of the limb is probably involved before on the lead is because of the involvement of the soft tissues. So so that would be the challenge. If the whole of the tumor has to be adequately covered, we may not be able to spare any lymphatic corridor that is soft tissue, cannot be spared from the radiation treatment field or volume that we currently call in our modern radiation technique. So if we are not able to spare a decent lymphatic corridor of normal soft tissue of the limb, this child may still have a functionless limb, and the problem of having distal lymphedema would be there, whatever the lifespan this patient lives. So in the setting of a non-metastatic disease, if we are still aiming to have a decent control, obviously, if this disease is not responding to chemotherapy, the chances are high this patient would relapse systemically, and I believe Dr. Sadaf would agree to it. The other option can be to go for amputation, or because we may not have an adequately functioning limb following radiation alone.
So as you shared, we did go for amputation because at the speed with which the tumor was growing, we had a fear that this will metastasize, because at this particular point in April, the CT chest was still clear. We thought that we can best offer him an amputation and then followed by adjuvant chemotherapy. Here, when we thoroughly discussed the MRIs, it appeared that the tumor was going as far as the elbow joint. So I have a question to Professor Masood Saab, that if a tumor is going there are signal changes up till the elbow joint, like up till the radial head, what will be his wide marginal amputation level?
Thank you, Aisha. If the tumor is not crossing the physeal into the elbow joint, then the physeal plate itself acts as a natural barrier. Or if it is even crossing the physeal plate and the articular cartilage is intact, then the articular cartilage of the proximal radius would act as a natural barrier and be my margin. So I would go through the elbow joint even if the articular
Radial head
cartilage
is
is
involved.
intact. Exactly.
Okay.
So
But
that's
like
my margin.
I was a bit more anxious maybe because the speed with which the tumor was growing. So I went through the supracondylar level just to remain on the safer side. Although I know this particular level will be difficult, it will show some complications with time as the bone might outgrow the skin and the child might have problems. So what do you have to say about that?
So बिल्कुल ठीक है. That's perfectly safe option of going above the elbow, and obviously you must have counseled the parents
Exactly,
of
sir.
the functional loss associated with that. There are long-term studies which show, and especially in the younger the child is, as they grow older, the length of the bone as it grows, it can outgrow the skin. There have been
Exactly.
published studies in the literature about it, but obviously those are secondary issues. As long as tumor doesn't come back and it doesn't spread, I think we are home and we can manage those problems locally.
Okay, sir. So the message I want to convey from this case was, first thing was that never underestimate a lesion in a child. Never underestimate any bone pain which is referred by a child or by their parents. Always take it seriously and investigate as thoroughly as possible. Now, these two X-rays that I have placed on the screen, they are just 1 month apart. On the left side of the screen, this was a child who had mild pain in the arm. So an X-ray was taken to see if there was any lesion or anything to the bone. And the X-ray appeared absolutely normal. But like just in a 1 month period time, here you see an involvement throughout the shaft of the humerus. This is typically an osteomyelitis appearance if you radiographically read it. I will request Professor Awais Saab to comment on the X-ray that we have after 1 month. So this child came to me with the left X-ray, and now I have decided to admit him and thoroughly investigate him before we go in for any treatment. So far, the soft tissues only show a swelling. There is no sinus or any discharging ooze from the arm. The patient does have fever, and there is a moderate swelling. So I will request Awais to kindly comment on this situation and what he will like to, how he would like to proceed about.
Thank you, Dr. Aisha. First of all, investigations start with the lab. And what are the lab reports in this patient?
The ESR was slightly raised. The CRP was fine, and patient is anemic. The patient does exhibit fever off and on. And as I said, the soft tissue conditions, sorry, I don't have a picture of his arm, but his soft tissues, the arm is swollen. There are no localized sinuses or any wounds or any draining stuff coming from the arm.
during the days of my training, this was a classical teaching that Ewing sarcoma and osteomyelitis, they confuse a lot at the stage of diagnosis because of this radiological presentation. So it is always better to do. Have you tried and found out that there is no abscess formation, there is no tuberculosis like clinical picture?
So the patient is still under investigation. I just found that the X-rays are very interesting, and I just wanted to relate to the previous cases that I've shown to just make a picture to the audience that how the bones they deteriorate within months.
Yes.
Even in osteomyelitis, although I doubt it to be chronic osteomyelitis, and in our limited resource settings when we don't really have the resources to get each and every investigation for every child, especially when they are not available under one roof. Like I have to send him to bone scan to one hospital, then for the MRI to another hospital. So it's quite a task for the family to get all the investigations done. But still, I don't
In
want to take any chances
mm,
for this particular lesion, but I will
in
just
this
want to know what are the few most important things to be done.
condition, I think that going for biopsy versus incision drainage will be more suitable to save the time, and histopathology will resolve the diagnosis.
Yes, sir, certainly. Okay, so I move on to my next case. This case has already been under discussion with Professor Vyas and Dr. Masood, and the patient had had a very, very long journey. So this was a 12 years boy who presented to us with left zone 3 Ewing sarcoma. So for clarification, a zone 3 of the pelvis involves ischium, pubis, but here you can see this was a presenting X-ray, and this X-ray is from March 2019. This was the first time the patient has presented to the hospital, and and, and here you can see that even the tumor goes beyond and involves the zone 2, which is the acetabulum. So this was a very tricky and a risky case as well, because as we know, zone 3 resections have their fair chances of complications. So at the time of presentation, his CT scan unfortunately showed METs. However, the bone marrow taken was negative. So the oncologist at Children's Hospital Lahore, she decided that we go on first with the chemotherapy. And this is after the first session of chemotherapy. I don't know exactly how many sessions of white chemo this child got, but it was at least 6 or 7 sessions. So this X-ray comes in October 2019. And at this particular time, the CT showed the METs had melted. And we can see the disease is very much contained now. This was the MRI. This was the first MRI of the presentation, where the mass measured 12 into 7 centimeter, and it involved the left medial upper part of adductor magnus brevis, and even went into the obturator internus and iliopsoas. So it was quite a huge mass. But the chemo response was amazing, and just in a few months, after few sessions, the tumor was almost reduced to half. The CT angiogram that we took in October 2019, it showed that the major neurovascular bundles were not abutted. At this particular time in October, since the patient had METs, but they had melted, at that time we decided to go on with the radiotherapy for this particular patient. Here I will request Dr. Bilal how he sees this particular decision, because it was not very, very cordially taken locally. We really had to struggle to get him radiotherapy. He was denied at few centers, and finally one center took up the decision, and they gave him quite a few sessions of radiotherapy. So Dr. Bilal, how do you see about it?
So, as I mentioned, radiation therapy can be used with curative intent in Ewing sarcoma. But what we need to define before taking a decision for radiation therapy, along with the surgeon in a multidisciplinary fashion, is to know the intent of radiation therapy. Again, I would like to emphasize that. So if the surgeon's colleague believe that the tumor is not resectable in a non-metastatic setting, radiation therapy alone for local control can be offered. But we may have to be a bit cautious what we are trying to achieve with radiation therapy alone, because in certain situations there are challenges at the time of local control with surgery, and therefore we opt for radiation therapy in a neoadjuvant setting where we intend to go for a lower dose of radiation therapy, which is not that low, like 2 or 3 fraction. It's for at least 5 weeks of radiotherapy, and the aim for that is to sterilize the margins, decrease the chances of having an R1 resection, probably where it is the tumor is abutting over the bone or the neurovascular bundle, so that the surgeon can go in and operate later on. But the important thing to know and decide before opting for radiation is to know the intent, either it for curative intent, full dose radiation therapy, which would span for at least 6.5 weeks. The dose is usually 55.8 gray in 31 sessions, versus the neoadjuvant dose where we intend to operate after radiation therapy.
Okay, and also, how much do you think is the radiotherapy is effective for the METs that are there in the chest? Do you think the chest radiotherapy helps?
Yes, I believe Dr. Sadaf also wants to add on something in this case. In the cases where we achieve a good response, the local disease can be dealt with one of the modalities after completion of radiation therapy. The microscopic disease in the chest can be covered with whole lung radiation bilaterally. But again, the intent, where in the situation where we see a very good response to chemotherapy.
So this was the, yes, please, Dr.
Because that's the comment that I wanted to make. So, Ewing sarcoma with lung mets. So even in terms of metastatic disease, the location of metastatic disease defines the prognosis. Now, out of all the metastatic disease in Ewing sarcoma, lung mets is considered to have the best outcome. And that is why at least we have completely at our center treated them with curative intent. And if you're treating with curative intent, so I think your intent is decided up front. So your therapy will not be completed if the patient does not get whole lung irradiation, despite the lesions disappearing after neoadjuvant or adjuvant chemotherapy. So you will call it completion of therapy once the patient has gotten local control, and then whole lung irradiation at completion of their chemotherapy. So that's the only comment that I wanted to make.
Okay, thank you. So for the local control, as we were planning with Professor Masood and Professor Avaisab, so I would like to hear the comments from both of them. This is the current situation, and of course, just to remind you that the world actually changed in March 2020. So this was a major undertaking, going in for an internal hemivalvectomy. We needed a backup ICU support, which was pretty much lacking in Punjab after this outbreak. So the situation changed. That's why we had to wait much longer than as we had planned earlier. So this is the current situation. This is the extent of the tumor. This is the latest 3D CT scan. So looking at these images, I will like to know the opinion of Professor Masood Umar and Professor Avesa, both, that how to proceed about it now in our current COVID-19.
डॉक्टर आयशा, ये जो आपका इस वक्त का सवाल है, इसका जवाब तो ये है कि मरीज की ज़रूरत है कि इसकी वाइड मार्जिन रिसेक्शन जल्दी से जल्दी होनी चाहिए।
जी सर।
कोविड का तो मेरा ख्याल है कि अब पता नहीं, देयर आर सो मेनी थ्योरीज अबाउट इट कि ये कितना अरसा चलेगा, लेकिन ट्यूमर की अगर हमें ये रिसेसिव स्टेज मिली हुई है तो इसका फ़ायदा उठाना चाहिए। आपने इसका वर्कअप किया है, तो इसमें ये बताएं कि जोन 2 में से कितना पेल्विस निकलेगा इसका?
सर फ्रॉम द
जोन 3 तो सारा ही जाएगा ना?
जी सर, जोन 3 सारा जाएगा सर। लाइक अगर ये इसकी 3D पिक्चर देखें तो उसमें तो द एसिटाबुलम सीम्स टू बी क्लियर and it's pretty much confined. The bone looks as normal as the other side. After these extended chemos, the patient has almost had 14 sessions of white chemo now, and patient also had at least 7 to 8 sessions of radiotherapy. So it had really contained the tumor now. And if you look at the sections, CT sections, there is some involvement of the interior wall of acetabulum. When I discussed it with the radiologist, he said that there's some involvement of the interior part of the acetabulum. So probably that part has to go.
जो इसमें नजर आ रहा है कि इंटीरियर पार्ट जो है ये हमें थोड़ा सा वाइड एंगल करते हुए जो एसिटेबुलम का रूफ है वहां तक तो मेरा ख्याल है कि जाना होगा।
Yes, sir.
और डॉक्टर उमर, आपका क्या ख्याल है?
जी सर, थैंक यू। इस पे ना डॉक्टर आयशा, आपके पास एमआर है कोई इमेज? ये सीटी तो मैं आता हूँ इस पे।
एमआर है।
अगर
this one is the latest one.
जी ठीक है, इससे कुछ अंदाजा हो रहा है। मोस्ट लाइकली ये देखें ना कि पोस्टीरियर कॉलम एंड ischium is also involved as is shown in the middle picture on the top. ठीक है। और अगर आप एक्सियल पे आए तो आपने जैसे कह ही दिया, सीटी पे एंटीरियर वॉल एंड कॉलम आर इन्वॉल्व।
यस सर।
राइट। एंड ये जो पिक्चर है जो ऑन द एक्सट्रीम राइट है, आई कैन नॉट मेक आउट मच, बट थोड़ा सा इससे ऊपर आना पड़ेगा, नीचे जाना पड़ेगा। टू हाई इन द आइलियम है ये, तो जोन 1 है, वहां तो डिजीज नहीं है गालिबन, राइट? या शुरू हो गई है यहाँ से। So the important questions that we need to ask ourselves as surgeons before we embark on a hemipelvectomy are: what is the extent of neurovascular involvement? Is the main external iliac vein and artery free of the disease? And out of the two major nerves going into the lower limb, which is femoral and the sciatic, can we save at least one of them? तो पहले तो ये था कि आप दोनों सेव करें, लेकिन at least if you can save one of them, patient can still walk. Third question is, what is the integrity of the hip joint? Can we save the hip joint, or do we have to sacrifice the hip joint? Fourth question is then the amount or the involvement of visceral structures within the pelvis, whether the tumor is growing mostly intrapelvic or extrapelvic. So intrapelvic में obviously surgery becomes much more tedious, challenging, and then you have to involve other specialties, like sometimes we have had it abutting the bladder, sometimes even the rectum, so we have to go in as a team and do diversion procedures accordingly. Now most of the time, and we are lucky, tumor is going outside the pelvis or extrapelvic, and that means we have to assess which muscles are going to be affected and which muscles are we going to resect. So the challenge or the decision is between gluteus medius and gluteus maximus on the outer side, which muscle will have to be resected. And obviously the functional outcome depends a lot on the resection of gluteus medius if it has to come out. Now, this seems like a type 2-3 resection where the whole acetabulum is involved, but probably I'm just assuming the hip joint is still sterile.
Yes,
So
sir.
the tumor has not breached the articular cartilage of the acetabulum. So that means the femoral head can be saved, but the acetabulum per se cannot be saved. So I would make a supraacetabular osteotomy at least 1 to 2 centimeters above the upper limit of the tumor in the acetabulum. Discuss after having discussed it again more thoroughly with my radiologist, क्योंकि ये तो एक दो ही कट्स हैं इसकी बेसिस पे यहाँ इस मीटिंग में
Yes, sir.
प्रोसीड किया जा सकता, but grossly, and then I would remove the posterior column, anterior column, and I would save the femoral head. And then comes the challenge of reconstruction. Once you have done a wide margin, clear margin resection, the challenge of I forgot to mention in type 3 resection, you have to sacrifice the adductor, the obturator nerve. Obturator bundle
Mhm.
whole has to go along the artery and vein and the nerve. So that is just abutting the inferior surface of superior pelvic ramus, and this is the structure maximally involved here. So that has to be sacrificed. So the adductor compartment origins have also to be resected. So the reconstruction next is the next challenge, where I would just do what I do maximally, the hanging hip situation, where I would just attach the femoral head to the remaining ilium with a pseudo-arthrosis type of picture, give the patient a derotation boot and a 1 kg traction for about 8 to 12 weeks, and then gradually mobilize them back to chair, and then they can even weight bear on a pseudo-arthrosis without any pain, as long as their femoral and sciatic nerves are intact.
Mhm. Yes, sir. Thank you for the comments. And of course, but like here, I want to just quickly want your comment in the current scenario. Do you think, like, of course, the tumor treatment has been greatly affected by the COVID situation, especially the surgical treatment. So, how do you see that? Like, should we do it as per routine or delay it? How do you see it? Like with the current emergency like situation in Lahore, where we don't have space in the ICUs. So God forbid if the patient needs critical, care, that will be greatly affected. So how do you think we can balance the risk and then
सारे बोल सकते हैं
Yeah, okay. This is a bigger challenge. I am also seeing patients being delayed with tumors because of COVID, because of a lot of hospitals not offering OPDs and even workup facility for these patients. And I'm seeing bigger diseases because of patients' inability to come immediately to me from outside Karachi or even within Karachi. So that is a challenge, but at least in our setup, we have always opened our doors to such patients. We have never closed them, never closed our OPDs. Our ICU is still functioning. So I mean, our challenge is different from your challenge. I can understand from a public sector perspective. This is a major surgery, and ICU one night stay is minimum. We also keep
preventive?
them in an ICU setting for at least one night for hemodynamic monitoring. This is this is not something ordinary surgery, not a surgery which even I do every month. I do maybe every 2 months or every 3 months, maybe 3 or 4 or 5 hemipelvectomies per year, not more than that. So the experience and the challenge is always experience is required, challenge is bigger every time we see this patient, and we need cooperation from blood bank, we need cooperation from anesthesia about post-op pain management and critical care management, at least for 1 or 2 nights for such patients. Now it is entirely up to your local setup that you have to decide about critical bed being available post-op. Yes, that's a very genuine situation, but I guess a balance has to be struck between the availability of resources and the fact that if you don't operate on such patients, they will certainly relapse, recur,
Exactly.
and we will certainly lose this patient. So a balance has to be struck. within your
So
own
I
setting.
just want to make a comment here, Dr. Masood.
Yes, please.
Yeah.
So do you remember, Dr. Masood, when the Italian team came to one of our seminars and how they had shared their experience, where they had talked about using radiotherapy upfront for local control, followed by delayed surgical resection. And I was trying to look up some literature on that because in this situation where we are not able to immediately do local control with surgical resection, is there a possibility that we use radiation therapy now, and maybe Bilal can comment on if that is a viable option in this situation where we do a delayed surgical resection, possibly even after completion of the chemotherapy, etc. Bilal, would you have a comment on this?
Yes, Dr. Sadaf, I already mentioned. I just want to mention it again. I raised my hand for the purpose that the pre-operative radiation can definitely be done and should be considered in such scenarios. What I would like to mention here, I heard some just now regarding the description of radiation therapy given to this patient. The pre-operative radiation for optimal local control in the pelvis cannot be limited to 7 or 8 fractions of radiation therapy. It is at least 4 or 5 weeks, at least 5 weeks of radiation therapy with a dose of at least 45 gray to all the involved area locally in the pelvis with an adequate margin and inclusion of the biopsy scar as well.
Okay, so you believe that he can have further radiotherapy if we have to wait?
Ideally, the radiation therapy should be considered and done in a continuous fashion. And another thing to consider is the dose per fraction. If it's being shared that the patient has had 7 or 8 fraction of radiation therapy, probably the dose per fraction would have been higher, and that seems like a very palliative dose of radiotherapy. So knowing the intent of radiation therapy is important, and there has to be an understanding between the surgeon and the radiation oncologist. So if somebody tells a radiation oncologist that this is somebody tells a radiation oncologist who is not connected to the multidisciplinary team, and the patient is referred as a metastatic Ewing sarcoma kid who just need radiation therapy for the purpose of palliation, the dose fractionation would be entirely different as compared to what we have just discussed. That we are expecting good local control. We are planning to go for a curative intent surgery. The preoperative radiation dose would be very different, which would at least be 45 gray and 25 fraction would mean that the patient would be undergoing radiotherapy continuously for 5 weeks, going to the radiation department daily, once Monday through Friday. And the dose per fraction is 180 to 200 centigrade. And I apologize to all the surgeons here. I am sounding like jargons, but the difference you have to make and appreciate is the intent of radiation therapy. The palliative course is shorter, and the curative intent course of radiation therapy is longer for 5 or 6 weeks.
Secondly, like this patient was denied radiotherapy when I repeatedly sent him to many centers and even talked to people over there. What was why they were not ready to radiate the child? They said that it's already metastasized, so they don't want to radiate it.
So we in Karachi and nationally at different forums have been discussing about pediatric radiation oncology. So the challenge here in Pakistan is that most of the radiation therapy centers are dealing with adult patients, and that too doing the practice of clinical oncology. That's more like a European approach rather than a North American approach where the radiation oncologist is entirely different from a medical oncologist who does chemotherapy. So mostly that's the dilemma in Pakistan, that most of the radiation oncology centers are busy with adult patients, and the dimension of work and the focus is towards the care of the adult patient. And pediatric radiation therapy is a very, very specialized field, and it has multiple different perspectives that one understands with training and involvement with pediatric multidisciplinary teams. So that's the dilemma in Pakistan. Only few centers have the capability of treating such children with radiation therapy, and that too with very limited site-specific support from radiation oncologists, the medical physicists who actually plan the patients, and the technologists who deliver the treatment. Another factor is that the organ at risk dose, the way you protect the normal tissue, because these patients are children are growing, there's an impact of radiation therapy on the long-term effects, because they can be survivors, and the horizon of radiation treatment planning and skills is entirely different for one does for the adult patients.
Okay, thank you. Thank you very much, Dr. Bilal. So here, I will request Saad if he can put forward the questions to the expert panel. I can't see the chat box actually, so we're ready to take questions. You can post your questions in the chat box, or I can also request Saad to unmute anyone who has a question. They can raise their hand. Meanwhile, we can have some remarks from Dr. Mumtaz, and from his experience of treating many bone sarcoma, very, very young patients.
Before comments, thank you very much. Before comments, I just want a question from my senior Professor Vaisab and Professor Mitchell. Actually, regarding the axial tumors, there has been a debate regarding the surgical or non-surgical. Then we have seen that multiple papers that, as Dr. Bilal was saying, that radiation has replaced the surgery to some extent. If we think that results are comparable to surgical resection and as a oncology radiation, as a replacement of surgery, radiation therapy, then the follow-up of the patient would be the same as we follow in surgical resection. This is a question from Dr. Bilal or Dr. Sadaf.
Bilal, do you want to answer the question? Otherwise,
Sadaf, I think you can proceed, and I can add on if there is anything.
Okay. So I think I would like to share our local experience. We actually reviewed the data of all the patients of Ewing sarcoma that we had treated in Karachi between ourselves and Indus Hospital. And we looked at outcome differences in local control between surgical resection versus radiotherapy. And this was just surgical resection and just radiotherapy. And what we found was that the outcome of patients with surgical resection was better than just radiation alone. And I think it's really important that we, at least in Karachi, feel that our radiation setup is up to the mark, where we're giving adequate doses of radiation and all. So one of the reasons also one has to understand that whenever we go for just radiation therapy, most of those tumors are unresectable, which means they are either very large or they're in a location where wide margin excision is really challenging. So already you're starting with tumors that have a little bit disadvantage. So whenever we talk about just radiation therapy, remember that the outcome may not be the same as when you have local control with surgical resection, even though the international literature doesn't completely support that. Now, in terms of follow-up, I think it is very different when we're giving radiation therapy to a child versus an adult patient, in a growing child, there are serious sort of long-term sequelae secondary to radiation therapy, and they really require very close sort of follow-up for growth retardation if it's the bone involved, but also for secondary malignancies later in life, which can happen 5 to 10 years later in life. So depending on what the location of radiation that the patient is receiving, they need close monitoring. And Bilal, I would appreciate you adding any comments to what I just said.
So I agree completely. I would not elaborate further except the fact that the series from local control from the intergroup, the clinical oncology group in North America, and CESS and EACESS in Europe showed the same results. Of course, radiation therapy to the pelvic region would need different kind of follow-up, at least from the radiation oncologist, which is still not the standard in our part of the world because of the lack of expertise. But these children having radiation therapy to the pelvis or the growing bones carry their own late effects. There is some risk of second malignancy there with radiation therapy, but should not be stopping us from using radiation therapy. The bone growth issues, the soft tissue fibrosis, especially in the pelvic region, radiation therapy, it has to be properly planned because of radiation goes to the gonads. And there are certain other long-term effects of radiation therapy.
So if we have 5 or more minutes to go. So if we have any questions to the faculty, please put it forward, Saad.
Or they can unmute their mic, so we can take.
They can unmute.
Question. Yeah, we unmute all those mics from participants for faculty. If anyone have any question, so he or she can ask directly.
Okay.
They just need to unmute their mics and ask.
So in the first case, the showed proximal to the radius, where you resected the posterior androceus nerve. My question is, what do you do for the nerve, and do you use the nerve grafting option or a tendon transfer option, and when do you?
Right now the patient is just immediately 2 weeks post-operative. So I have not gone for a tendon transfer or anything right away. I'm just waiting. The patient, of course, because the posterior androceus nerve is clearly gone, the patient cannot extend fingers. The wrist extension is there. So I will monitor the child for another 6 months at least, and then afterwards probably will go for a tendon transfer.
Dr. Aisha, if I may add another comment here.
Yes, sir.
So, as we have recognized the importance of discussing with the pediatric oncologist and radiation oncologist regarding the intent of local treatment and overall care, I would also like to mention and emphasize on the importance of discussing the post-operative finding, which are there from surgery, as well as discussing the histopathology within a multidisciplinary team, having the histopathologist, pediatric oncologist, and the radiation oncologist regarding this, the first case as well as the second case, for the need of the post-operative radiation and the duration and management with post-operative chemotherapy.
Exactly. Yes, sir. Definitely we do that.
Because in certain situations, for closed margins and having necrosis over the tumor after preoperative chemotherapy and the surgical margins being close to the tumor, we need to add on local radiation therapy. And for the planning of post-operative radiation therapy, the radiation oncologist also relies upon the preoperative finding from MRI and CT scan, all that has been done before chemotherapy and before surgery, as well as the surgical treatment that patient has already gotten, which of the planes were exploded, violated or contaminated during the surgery, the surgical scar, and the way flaps or implants have been placed for operatively. They are really important for a radiation oncologist to plan radiotherapy.
So I agree with Dr. Bilal's comments here, and like, you know, so there are certain challenges of our setup. Like you mentioned, Dr. Aisha, that how these patients, you know, after having gone through multiple different sort of physicians and gone through multiple different procedures. Let's say a lot of these patients come after having these incision and drainage and incision and debridement and all those sort of things. For example, we had a number of Ewing sarcoma patients who were localized. They actually had completely negative margins as well. But prior to coming to us, they had been through so many manipulative surgeries that we chose to treat them with radiation therapy because we felt that there was a lot of contamination and possible sort of, spillage of tumor prior to even coming to us. So a lot of those patients, we have chosen to use radiation therapy in those patients. So I think just something to think about in these patients that have been through all these procedures.
Thank you, Dr. Sadaf. So do we have any questions in the chat box, or we can end the session now with some final comments coming from Professor Webb and Professor Masood?
Thank you very much, Dr. Aisha, for holding and conducting this very useful seminar. I hope we all have benefited, and I believe that patients will be benefited too, inshallah, and keep it up in future. Thank you very much.
Thank you, sir. And Professor Masood?
Thank you very much for organizing, I think, great landmark webinar today, the first of its kind on orthopedic oncology. I'm enjoyed it thoroughly. And so as Dr. Bilal pointed out, next time, inshallah, we'll bring the histopathologist also. And to show the residents what are the pre-op and post-op changes and how do you assess them. They can bring in some book pictures at least if you are conducting, and we have pathologists from Karachi, so they can show some book pictures just to add to the knowledge of the residents. Anyhow, very good beginning, and inshallah we will continue. We'll have some more. We'll have try to organize some more on orthopedic oncology perspective, inshallah. Thank you.
Okay, thank you to all of you, actually, to the wonderful people who joined us and enlightened us and actually helped our patients. And I believe that just if we learn a few important things about childhood bone sarcomas, we can tremendously change the life of our patients. I'll just conclude with this picture. This boy had presented to us. On the left is his picture few months earlier when he had a osteosarcoma involving the proximal 2/3 of humerus. It was metastasized, and at this time we had offered him an amputation, a disarticulation at the level of shoulder. However, the parents denied, and just after a few months, this child came in with this huge mass, which was not even resectable now, and even with secondaries around the knee. So this picture just shows the miserable agony that the parents, the children, and go through in their ignorance. And we must, propagate. The least we can do is actually educate these children and maybe show them these images so that they learn from others' mistakes and make prompt decisions. Okay, so see you all, inshallah. I hope we don't have any questions unanswered. Saad, do we have any questions?
No, we do not have any questions yet, but participants are appreciating. and
Okay.
they are very.
We can also tell them about the ACCME certification for the
Yeah.
webinar.
For that, they have to fill the evaluation form, which is in the chat box I have mentioned already. And one more thing I want to mention, that the presentation and the whole recording will be uploading soon at our Orthocon YouTube channel. So you can go there and subscribe our channel. So all the presentations and all the webinars will be uploaded soon after this presentation.
Okay, thank
So it
you
would
very
be
much.
wonderful if you can, continue this sort of forum and, multidisciplinary sort of, because I think this is learning, we're all learning from each other. And, in the end, not just residents, but also patients benefit. So I think it'll be really fantastic if this could be like a regular event.
Yes, inshallah. Thank you very much. Thank you again. So here we take a leave and see you next time, inshallah, in another webinar.